Hello everyone, my name is Nicole and I'm a dietitian working at Salford Care Organisation. My ultimate career goal is to help people age well through appropriate nutrition advice at the earliest opportunity. To achieve this, we must detect those at nutritional risk early. That's why I've been investigating the use of the Malnutrition Universal Screening Tool, also known as MUST, which we currently use in Salford. MUST is identified as a reliable and validated screening tool. The MUST scoring system, which evaluates three key components: body mass index score, weight loss score, and acute disease effect score. And each component contributes to the overall MUST score, which ranges from 0 to 6 to detect risk of malnutrition. If you'd like to know more about me and my research interests, you can click on the link at the bottom of this poster to visit my biography on the ArcGM website. Now, let me share why I pursued a pre-doc fellowship and how it has shaped my journey. I visualized my initial goals as individual puzzle pieces, each representing different aims or objectives. I wanted to use the fellowship to help me define my research question and gather my thoughts and ideas. And trust me, I had many to begin with. I aimed to connect with like-minded individuals, both clinicians starting their research journey and experienced researchers willing to share their knowledge. As the fellowship progressed, these pieces came together to form a cohesive picture, representing my achievements and the integration of my efforts. Each goal was a piece that didn't make sense alone, but now they all fit together to show my journey. During my fellowship, several experiences stood out as particularly valuable, such as the supervision and guidance I received from various forums and individuals. Here are a few highlights. The ArcGM monthly meetings. These meetings were instrumental in learning and sharing experiences with other fellows. We realized we faced similar challenges, and seeing how others overcame these issues gave me confidence to continue with my plan. The Nutrition Research Group at the University of Manchester. This was led by dietitian researcher Sorrel Burden. Presenting my research ideas here was eye-opening. The feedback, always honest and constructive, was exactly what I needed to improve my work. It helped me understand my lab researchers better and appreciate different research designs, such as deciding between a systematic or scoping review. Healthy Aging and Dementia Research Team Meetings. These meetings were always interesting and provided opportunities to present my research idea and progress. The feedback helped me develop it further, and I made strong network connections, learning much about research methodologies, paper submissions, and proposals. ESPEN Congress in Milan. Attending this Congress as an Abbott Strength ambassador was an outstanding experience. I met researchers from all over the world. You can find me on the photo amongst a few of them. I learned from the latest evidence-based practices and presented a CPD session to our dietitians on muscle health, a key aspect of my research interest. I would like to thank my supervisors, Kate Grimshaw and Emma Vardy, for their invaluable guidance and support. Their expertise and encouragement have been shaping my pre-doc journey from the start. However, the journey wasn't without its challenges. At times, I found it tricky to navigate the intersection of research and clinical practice, summarized at the top of the poster, middle column. My research pathway consisted of conducting thorough literature searches to inform my study, formulating hypotheses based on existing knowledge and gaps, which often change and is still changing, collecting and analyzing data to draw meaningful conclusions. Then there's always going to be my clinical pathway, screening patients effectively to identify those at nutritional risk, implementing appropriate dietetic referral criteria to ensure accurate assessments, monitoring patient outcomes to evaluate the effectiveness of dietetic intervention. But throughout, I developed strong navigation skills to balance clinical duties and research commitments. For example, balancing time between research activities and clinical duties was crucial to maintain progress in both areas, which I did not find easy. Integrating research findings into clinical practice required a lot of collaboration and good communication with the clinical team. Achieving a significant impact on patient care involved translating research insight into practical, actionable strategies, which I'm still trying to do now. So my output then. One of the key areas I focused on was the interpretation of existing mass data, which I have summarized as a service evaluation report, hoping to publish soon. Our results indicate that the use of the MUST is ineffective in triggering appropriate care plans and timely dietetic interventions for older adults. You can see on the pie charts that while a high percentage of patients had their MUST scores recorded, 87%, nearly 50% were inaccurate. The accuracy of these scores is a significant issue and mainly due to not scoring for acute disease effect and only 25% of patients having recorded weights within 12 hours of admission. Inaccuracies could lead to underestimating the risk of malnutrition and missing timely interventions. The MUST data came from an existing QI project, which showed that nutrition education and dietetic ward presence had a positive impact, reducing both the length of stay by 3 days and readmission rates by 11%. This suggests that addressing nutritional needs can lead to better patient outcomes. Please scan the QR code for the MUST service evaluation abstract. This led me to a crucial realization about my project idea, as summarized in the conceptual map top right corner of the poster. Initially, I thought the MUST was the problem, and I need to find either a new screening tool or a more suitable one. Then I considered whether it was the tool itself or how we use it. The service evaluation showed that MUST scores are often incorrect, meaning not all high-risk patients are referred to dietetics. This led me to believe that maybe this issue is at what point dietitians get involved, because the current referral criteria is MUST 2 or above, suggesting a high MUST score, but if we can't rely on the MUST score being accurate, maybe a hybrid model could work better. So, for example, age triggers an automatic referral to a dietitian instead of relying on a high MUST score alone. Perhaps using this at the front door, which is our emergency assessment unit to start with, is also a good idea. This way we ensure that those over a certain age get the professional attention they need, while also raising awareness and vigilance on admission and discharge from hospital. My literature search has informed me of the use of a diagnostic tool like GLIM, which stands for the Global Leadership Initiative on Malnutrition. GLIM helps to combine all aspects of malnutrition, including the overlapping features of sarcopenia and cachexia, by describing disease-related malnutrition which can be driven by inflammation or undernutrition catabolism, both resulting in nutritional deficits seen in patients who are clinically unwell, including changes in their body composition. Based on my extensive reading, research suggests that GLIM criteria are highly sensitive and specific, but the application of GLIM in clinical care settings remains challenging. It is well discussed in research, and during this year's ESPEN Congress, the GLIM committee announced that more emphasis will be put on the first step, which is nutritional risk screening. For my project, I'm interested to see if diagnosing malnutrition using a set criterion, such as GLIM, rather than just relying on MUST to assess nutritional risk, would provide better care outcomes in older adults, particularly when aiming to address the complexity of healthy aging in hospital. Please scan the QR code for my project proposal summary. So moving on to reflecting on my journey, I have learned a lot. At times it felt like slow progress, as if I hadn't achieved anything. But small steps with big impact have always been my motto as a dietitian. I found this quote very fitting. Treat your research like a pizza. Take it one slice at a time. Savor the cheesy wins and don't stress about the crusty challenges. Remember, even the messiest experiences can be surprisingly delightful. So in conclusion then, this year has been transformative for me. After this year, my initial puzzle pieces have formed a jigsaw. I'm much clearer on my research question and how to approach it. I achieved a lot. I gained insight into available screening methods. I established valuable contacts in research and hospitals. I clarified the current limitation of the MOS screening tool. I improved my literature search, writing, and analyzing skills. But learning never stops. I'm starting on a new jigsaw puzzle, symbolizing new goals and aspirations. I'm ready to continue writing my PhD proposal, look for funding options, and continue to learn and work as a dietitian. Thanks for listening, and if you have any questions or are interested in discussing my research idea further, please feel free to connect.